Aloha and welcome to our lecture today. We are going to spend some time discussing glucose regulation. As we all know, type 1 and type 2 diabetes are chronic illness that affect many people here in the United States and particularly here on our islands as well, especially type 2 diabetes. So we're going to spend some time discussing it carefully over the next couple of sessions, and I encourage you to get curious about this topic. There are so many different areas that we could dive deeper into on the topic of glucose regulation, but it's impossible to cover all of it. You will be caring for many patients that have glucose regulation problems as a nurse. And so I encourage you to look things up, learn some things on your own, ask questions of me and your peers and your clinical instructors and the nurses that you're working with, and most importantly, you can learn a lot about diabetes from the patient. Talking about patients with their illness, those who are willing to discuss it, sometimes have amazing insight and knowledge about their own condition. And they have shared so much with me about different disorders and diseases because nobody really understands things as well as someone who may be experiencing it. So, with that being said, we're going to get started today. This is our introduction to diabetes mellitus. And so let's discuss glucose regulation. Every cell in the body uses glucose for energy. And you'll notice during my talk, I will use glucose and sugar kind of interchangeably. But generally speaking, when we are talking about glucose, we're talking about the glucose, which is the sugar that is in our blood. And so our pancreas actually regulates our blood glucose by secreting insulin. Okay, and I want to take a moment here to just kind of differentiate between the two different types of insulin. Now, there's endogenous insulin, and this is the insulin that is made by our body via the pancreas. And there is also exogenous insulin, and this is the insulin that we inject into our patients with a syringe. So one of the first things that I want you to understand before we even talk about what insulin does is that there are two forms of it: endogenous, made by the body, and exogenous, which we give via injection. So, our pancreas not only secretes insulin, but it also secretes glucagon. The beta cells are the cells that are in our pancreas that produce the insulin, and the alpha cells are the cells that produce the glucagon. And so what we're looking at right now is kind of like a close-up of the pancreatic tissue as we see the beta cells and the alpha cells. And the islets of Langerhans are where this particular area is in the pancreas, that all this takes place. All right? And so insulin is a potent anabolic hormone. Anabolic means to build up. That is stimulated by the presence of serum glucose, right, or sugar. We said it was produced by the beta cells in the pancreas, and it facilitates the storage of carbohydrates, which is the same thing as glucose or sugar, fats, and protein nutrients into all the cells of our body. And insulin is released in response to eating. So when we sit down and we enjoy a meal, insulin is released. Glucagon can be thought of as the opposite of insulin. It is a potent catabolic hormone. Catabolism means to break down, that is inhibited by the presence of serum glucose. And it's produced by the alpha cells in the pancreas. We mentioned that before. And it actually facilitates the release of carbohydrate, which is glucose, sugar, fat, and protein, nutrients from the cell. And so it's released in response to low blood glucose, exercise, starvation, and stimulation of the sympathetic nervous system. So let's think about this for a second. When we are in fight or flight mode, and that is when our sympathetic nervous system is being stimulated, it makes sense that we would probably need to have more circulating glucose. Why? Because we want our muscles to be able to function at their best, right? We want to be able to run away from whatever the threat is that is after us, and in order to do that, we need our body to be awake, alert, oriented, and ready to run, okay? And that really requires us to have more circulating glucose. Does that make sense? I hope that it does. And so glucagon gets released when we have low blood glucose, and we need some, when we're exercising, right? Because we're using a lot of energy when we exercise, when we are in a state of starvation, right? And we're not taking in any calories. And of course, like the example we just talked about, when the sympathetic nervous system is stimulated, all right? So when you're thinking about these topics, if you make sense of it at the very beginning, right? We're gonna be building on all this information. So take some time to think about these things. So this slide is a very important slide for you to study. And what it does is it provides us kind of like a picture of what happens when our blood glucose gets low, too low, and when our blood glucose might get too high, and actually how the body balances out. At the very bottom here, you can see this is how normal blood glucose levels are achieved. So what we mean here is that maybe our blood glucose levels are a little bit low when we wake up in the morning, in which case the alpha cells will release some glucagon, all right? And then our liver can release some glucose into our blood so that we can achieve a normal blood glucose. Maybe we decided to go to Krispy Kreme and we went a little overboard and had 3 donuts. Well, I can pretty much guarantee you that your blood glucose might shoot up a little bit after 3 donuts from Krispy Kreme. And what happens in that case is that our beta cells will produce some insulin, okay? And our cells will convert the excess glucose that we have, right? Either it will get stored later, right, for use later, or we will actually burn up some energy by maybe going for a walk around the block. But either way, if we have a donut and our blood glucose level is high, our cells are going to convert this excess glucose into fat stores, maybe for later use. And a lot of times where this goes is into our adipose tissue. And so it can then be used at a later time, but it can also contribute to us gaining weight. And we're going to talk more about that as well. But what happens is the beta cells will produce this insulin, then the insulin will help us store the circulating glucose or sugar for use later. And this is how our blood glucose, normal blood glucose levels are achieved. All right? So the idea here is that our blood glucose is never too low and it's never too high. What we like to have is what is known as a euglycemic state, which is a balance. Okay? Homeostasis, that word's going to come up again and again and again, and it has to do with balance in the body. All right? So we don't want glucose too high and we don't want it too low. Okay, so one of the main reasons is because of our brain. The urgent need for glucose regulation is because our brain needs our body to regulate blood glucose. So nearly every cell in our body requires insulin as the key to unlock the glucose door, all right? So let's take a second and take a look at this slide and think about this. This is a kind of an image of a cell here, and I want you to think of the key here in the image as unlocking the door to the cell for blood glucose to come in and go out. Okay, so nearly every cell in the body requires insulin as the key to unlock the glucose door. Nearly every cell can make its own emergency supply of energy when glucose is unavailable, but the brain cannot. Glucose must always be available to enter the brain freely. The brain cannot make its own energy during hypoglycemic states. Therefore, there is an urgent need for serum glucose regulation. Okay, so now that we understand one of the most important reasons for glucose regulation is so our brain is able to get the glucose, right? Because if we do not have good energy in our brain, we cannot function. We cannot be awake and alert and oriented and do all the important things that we need to do every day, all right? And so we are going to talk a little bit about how our glucose is stored and released. Now, you can always go back to some of the previous slides, and I encourage you to review these multiple times so that you finally kind of get this understanding. So liver, muscles, and fat store and release blood glucose, okay? And so we said that it can be stored as glycogen when our insulin is stimulating our body to store, okay? And we said a little bit ago that even excess glucose will be stored as fat. And so here we see in this bottom picture, we see that kind of abdominal adipose tissue underneath the skin. That's what we call subcutaneous fat or adipose tissue. And so what happens is, this is a good opportunity for us to take a second and think about why carbohydrates are getting such a bad rap these days. The reason is because when we eat carbohydrates, even something like a cracker, okay, it will, okay, be converted to glucose in our body. So if we eat too much of any type of carbohydrate, which is then converted to glucose, and we begin to store this excess glucose as fat, we will gain weight, okay? And so anabolic means to build up, okay? The anabolic process means to build up, and we know that the liver and the muscles store glucose as glycogen when stimulated by insulin. The catabolic process, meaning to break down, is when our liver and our muscles release the glucose when stimulated by glucagon, all right? And so when we are active, okay, we will have this release, okay, so that we can do things, be active. We are using up energy when we're exercising. And the thing about it is, once we have stored a lot of this up as adipose tissue, right, it's a little bit harder to get that to release as energy, as we all know. Those of us who are concerned with weight gain, right? It's definitely difficult to get rid of this excess glucose that's stored as fat, okay? So, the insulin and glucagon relationship. When blood glucose level is high, insulin is released and glucagon is inhibited. So remember, insulin unlocks the cell to allow the glucose in. When blood glucose levels are low, glucagon is released in order to raise blood glucose levels. Glucose moves out of the cell and into the bloodstream. So again, we can take a look at these images and kind of help us have an overall picture of how this balance occurs in our blood. Now, this is in a person who does not have a disorder of glucose regulation. So now we are going to define some of the types of dysregulation in glucose. First of all, we have type 1 diabetes, okay? Traditionally known as juvenile onset, usually. It's insulin-dependent diabetes mellitus, and what this means is that their pancreas does not make insulin. So type 1 diabetics have a failure of insulin production, okay? So the pancreas does not produce insulin. The type 1 diabetic needs insulin. They need exogenous insulin, insulin that we give with a syringe via injection. And even if they're not eating, so even if they're NPO, they need insulin. If they do not get exogenous insulin, they will break down muscle and body fat for energy and risk developing diabetic ketoacidosis. And we are not going to talk about DKA today, but it really is important for you to understand that a type 1 diabetic must have a source of insulin, even when they are not eating. It's usually about half the regular dose. Now, I said earlier that type 1 diabetes has what we refer to as a juvenile onset, meaning that it's a pediatric disease. However, the onset may be as an adult, okay? And so what else causes type 1 diabetes? Researchers believe that type 1 diabetes can be triggered by a virus such as the common flu or cold. Frequently, type 1 diabetes comes on in the weeks following a viral infection. Pancreatic injury may be another cause. Very rarely, type 1 diabetes can be triggered by trauma to the pancreas. If the pancreas is surgically removed, the body also loses its ability to produce insulin, which then causes type 1 diabetes. So, I'm going to tell you a story. I know a young person who graduated from college, and upon graduating from college, so he would have been in his 20s at that time, wanted to join the military. He went and did the physical to join the military, and for some reason, they found that he had sugar, glucose, in his urine, and that also his glucose levels, his serum glucose levels, were high. Now, he was never a diabetic. He did not have diabetes in his family, and they kept referring him to different doctors. And at first they told him, well, it looks like you're a type 2 diabetic. Why did they tell him that? Because he was in his 20s. And we have this idea that type 1 diabetics are usually juvenile onset, pediatric patients. However, he was very, very thin, and he had no other risk factors for developing type 2, meaning that he did not overeat, he was not overweight, he lived a healthy lifestyle. And I said to myself when I heard about this, I wonder if he is actually a type 1 diabetic. And so as the story unfolded, it turned out that he was indeed a type 1 diabetic. And he does recall actually having a pretty severe illness several months before all this came about. And so it is very possible in his case that a viral illness caused his type 1 diabetes. It is now several years later, and he is fully insulin dependent. And he was very, very quickly after his diagnosis of type 1, and they got him on insulin. He said that he felt like a different person. He was always extremely tired before, felt very lethargic, and once he got started on insulin, it really changed his life. And so I want you to know that it's important to talk to people, it's important to understand their history, and it's important to be able to listen to what they have to say, right? Their story can help us understand what it is that has happened. Okay, so that's about type 1 there, right? So it can be on onset as an adult. Now, let's talk about type 2. Type 2 diabetes is adult onset. It is a non-insulin dependent diabetes. And what this means is they are not dependent on insulin, okay? That means that their pancreas does make insulin, okay? Their pancreas does make insulin. So, in type 2, it's usually a slow, insidious onset. So what does this mean? This means that it happens over time, okay? It happens over time. And the difference, this is a big difference between type 1 and type 2. Type 1 can be regulated and even halted by pre-diabetes action plan. We're going to talk about that. In the type 2 diabetic, we usually see insulin resistance, dyslipidemia. These folks may use insulin during periods of hospitalization, surgery, and illness, but they are not insulin dependent. So we're going to talk about what all those things mean. So first of all, pre-diabetes is when you have a hemoglobin A1C blood test that is about 5.7 to 6.4. Okay, so what this means is that you've gone to the doctor, you may be having some of the symptoms of diabetes, which we will talk about, and your doctor checks your blood and says, you have a hemoglobin A1C that is between 5.7 and 6.4. Let's say it's 6.2, okay? What they're saying is we are concerned that you are developing type 2 diabetes, and let's put a plan of action into place to see if we can get your blood sugar under control due to lifestyle changes, all right? So they would be avoiding refined carbohydrates. Krispy Kreme donuts, it's an example of a refined carbohydrate. We would want them to cut back on their sugar intake, drink less alcohol, eat healthier foods, get good sleep, keep an active lifestyle, and reduce the portion size when they are eating. So lifestyle tips obviously here that involve diet and exercise and probably stress reduction, okay? Because these all show that they can help a pre-diabetic get their blood sugar under control so that they don't necessarily develop into full-blown type 2 diabetes. So reducing portion size and plating food accordingly is one of the steps in a pre-diabetes action plan. So here we can see an example of a plate. First, it's a 9-inch plate, meaning that we're not using great, huge, big plates to plate our food. We want to fill 1/4 with some whole grains or starchy vegetables. Like whole grains would be like rice or whole wheat bread, and maybe starchy vegetables like carrots. We want to fill 1/4 with a lean protein. This would be like fish or boneless chicken breast. But it could include a lean cut of red meat as well. And then we really want half of the plate to be filled with a little more of the non-starchy vegetables. So we do see some carrots over here, but really we really want more leafy greens, spinach, leafy greens, other types of vegetables that are low in carbohydrate. And eat a small amount of fresh fruit. Drink skim or 1% milk, or more importantly, just stick to water, okay? And so this is kind of an idea of how a nurse might help a patient learn a little bit about reducing portion size and plating food accordingly. So we said that the type 2 diabetic, once it was happening, okay, once we have no longer been able to use diet and exercise and stress reduction to control our blood sugar, what we see in the type 2 is something called insulin resistance, all right? And so what happens is when there's excessive carbohydrate intake, maybe a genetic predisposition, coupled with a sedentary lifestyle and weight gain, we see a phenomenon known as insulin resistance. And so what happens in insulin resistance is that you eat a meal, the insulin is released, our body cells are no longer as sensitive to the insulin, okay? They're kind of resistant to the insulin. The glucose from the meal is then stored as fat, okay? Why? Because the insulin isn't unlocking the door of the cell for glucose to go in, all right? And so instead, that glucose from our meal gets stored as fat. We feel tired, we feel hungry, and the cycle continues, okay? So remember, this is very much a problem with the type 2 diabetic, insulin resistance. When the effect of insulin on muscle, fat, and liver cells becomes less effective, This occurs with both insulin produced in the body and with insulin injections that we give to the patient. And we've got to remember that what ends up happening here is that higher levels of insulin are needed to lower the blood sugar. Okay? A dyslipidemia is another hallmark of type 2 diabetes. It affects about 50% of the patients. And what it is high elevated cholesterol and triglyceride levels. And what it does is increases our risk for cardiovascular disease. And that is because this elevated levels of cholesterol in our blood can cause plaques in our arteries that end up forming blood clots that can cause things like heart attacks. So dyslipidemia is another consideration. So let's talk about some of the symptoms of diabetes. Polyuria is excess urination. They may feel like they are constantly needing to go to the bathroom and urinate. The reason for this is that there is a lot of sugar in their blood. It's kind of spilling over into their urine, and water tends to follow sugar. And so a lot of their water will be pulled into their urine, and they will be peeing a lot. Polydipsia makes sense. Excess thirst would maybe then develop because they are peeing a lot, urinating a lot, getting dehydrated, feeling very thirsty, okay? And polyphagia, and this is a longer word for excess hunger, okay? So we just kind of talked about that when we talked about that cycle, right? Because the insulin is not working as well to unlock the cell, what we've got is we've got the 3 P's, right? This is the hallmark, 3 P's: polyuria, polydipsia, and polyphagia, okay? Fatigue and lethargy as a result, and recurrent infections. We know that blood sugar levels that are raised are a higher medium for infection, okay? The bacteria can be feeding off of the sugar in the blood. Here we see an example of recurrent yeast infection. This one is in the mouth, on the tongue. This is what a yeast infection looks like. This can be kind of itchy or painful. Also a non-healing foot ulcer we see here. And someone may be a type 2 diabetic and not even realize that they have a small blister on their foot. And then it turns into a non-healing foot ulcer like the one that we see here. So these are some of the symptoms that we might see. Diabetic coma, okay, in a severe state of glycemic, problems with our glucose regulation. What we see here is hyperglycemia, when blood sugar is too high, okay, or when hypoglycemia occurs and blood sugar is too low, okay? So remember, we talked about homeostasis. If our blood sugar level becomes dangerously high or dangerously low, our patient is at risk for going unconscious. So if you ever come upon an individual who is unconscious, one of the first things you might want to do, in fact, I encourage you to do this absolutely 100%. Check their blood sugar. Check their blood sugar, okay? We want to know Is it too high or is it too low? If there's too much glucose in the blood, this can cause glycosuria. We talked about this a minute ago, too much sugar in the urine. Okay? This can cause polyuria, lots of urination, and eventual dehydration. We're talking about a blood glucose in excess, greater than 600. Okay? They can become so severely dehydrated that two things can happen. There can be swelling in their brain, and they can have compromised blood flow to their brain as well. Now, either of these things are going to contribute to some neurological symptoms. We might see coma, we might see delirium, drowsiness, hemiparesis, which might be like some weakness on one side of their body, lethargy, seizures, and sensory deficits, and even some visual disturbances. So these are all kind of some examples of some neurological symptoms that can happen when our blood glucose becomes dangerously high, okay? And so the opposite problem can also cause the person to have a neurologic problem, okay? So hypoglycemia, when the blood glucose is too low, usually less than 60, there is also a risk of coma and brain death. And so remember, the brain cannot make its own glucose. So if our blood glucose levels are too low, our brain is not getting glucose, we can also become confused, we can become agitated, and we can actually become unconscious. So if you ever come upon an individual who is unconscious, you definitely want to know what their blood sugar is. And either one, too high or too low, can cause neurologic problems, coma, and if untreated, even death. Okay? So that is all for today. We are going to pick this up next time with more topics related to glucose regulation. I thank you for your attention, and until next time, aloha.